go ahead and we'll start the last segment of or the last question and answer session. And I think hopefully we can get Eric up here as well as soon as he's finished. There were some general questions. We'll start with those first. The first question was, I guess, a lot of us talk about tumor board, and one of the questions was, what is tumor board? Who's on a tumor board? And what happens in tumor board? So Diane, can you just, I'm sure they're all very similar across all places.
Yeah, absolutely. So tumor board typically is a true team approach where you'll have nuclear medicine physicians, surgeons, sometimes gastroenterologists, interventional radiologists for sure, medical oncologists, and we present cases. And so, a patient will be presented and the radiologist is typically responsible for reviewing all the different imaging. So if a patient has a CT plus a PET scan plus an MRI, we'll show all of those, and we sort of joke around. You're on the board. You're the chairman of the board for that moment as a patient, and then we all kind of together come up with a plan of what's the right approach. Is there a surgical option? Should it be an interventional radiology option, or should we go systemic with another type of treatment? So it's an opportunity to review all the cases with all the sort of key stakeholder clinical folks in the room.
I think we also have pathology as well. I'm sure you've.
Oh, yeah, and pathology as well.
Yes.
Yeah, we have review for pathology.
And so the follow-up question came from the audience was, how often would patients be reviewed at a tumor board? How often?
Yeah, so that's different in every case. So for example, for us right now, we review every patient that's going to get PRRT. I think that's extremely helpful. And I will also say all of our nurses and nurse practitioners and or PAs that are involved in neuroendocrine also attend those meetings. It's a great opportunity for learning, so our fellows are there too. But depending on the center, sometimes it's every neuroendocrine case, sometimes it's just the more challenging cases. So I wouldn't say that every single patient with neuroendocrine is presented. It's usually more when you want to get consensus, for example, in someone with liver metastasis, and you're not quite sure what's the right approach.
And I guess a question to the entire panel, one of the things was about how do we deal with, or how often are there issues with getting these therapies approved by insurance companies? How do you go about dealing with the denials, and what strategies can you offer to patients and try to help them through that process? So denials of therapy from insurance company. How often does it happen, and how do you deal with it?
So painful. So painful.
All the time. First, we throw the phone.
I know, right? It's like,
and scream at the person.
The three letters or numbers I hate the most are P2P, peer-to-peer. So actually, generally, a lot of the initial workup is actually not denied. So the CT scans, the standard blood tests are usually not denied. And for a usual first workup with a new diagnosis of neuroendocrine, it's usually the PET scan is usually included. It's the follow-up that's a problem. In general, surgery is never ever denied. Could you imagine the headlines if, Aetna denies cancer patient surgery, patient dies? I mean, that does not look good. So surgery is usually actually pretty well covered. But then it becomes complicated because of a lot of the data that are available for neuroendocrine. There's not a lot, so sometimes you want to use some new drug and the company won't cover it, right? Or they want to try immunotherapy and they'll be like, nope, no data for that. We're not going to pay for it. Or you want to get a PET scan. Right? You want to get a dotatate scan. They give you maybe one more a year after your surgery, and they say, nope, no more. You have to use CAT scans. And then, unfortunately, it's just kind of about money, right? It's about the cost, right? You can get it, right? I mean, if your last name is Wayman and you want to just write a check, you can just write a check. Yeah, no problem. But obviously, that's exactly right. I can't afford it, but so some of those things can be a little bit more complicated. And so what we have to do is we have to call. There's a whole process. So we submit it, and then our team calls, and the nurse calls, and we send the paperwork, and then we have to set up a peer-to-peer, and then we talk to the peer-to-peer, and they say, look, you can't have it. You got to get your CAT scan first. Fine. So you cancel the PET scan, then you get the CAT scan, and the CAT scan's inconclusive, and then you try to order the PET scan, they deny it again. So it's a game that we have to play. It's just tedious. It's time-consuming, and sometimes it's a little bit easier coming from like Memorial Sloan Kettering than it is coming from a community practice. But it's still something that we all have to deal with frequently, especially for chemo sometimes.
Yeah, one of the things that is helpful is the National Cancer Care Network guidelines, or NCCN guidelines. They are sort of consensus groups that decide the appropriate tests and therapies for a patient with X disease. And so if they're on the guidelines, Medicare says that they will approve it, and other insurances usually follow suit. So for those of us on the guidelines, we're always thinking about that. You know, obviously we want to use the best available data to say what should be done, but we want to make sure it's on there. So that's a way that can help us often ensure that the patients are getting the appropriate tests.
I want to make one further comment about this issue, and that is that when a physician is talking to another physician who works for the insurance carrier, I know I always ask for the credentials of that person, because very often they are not a tumor specialist. Very often they could be anything, a psychiatrist, anything. So I document that first. And then I see whether or not their response to our request is consistent with the known guidelines. And if it's not, I let them know that in the event that they are making a determination on the basis of financial considerations against the guidelines, I will report them to the state's regulatory board. And I've been a participant in reporting several individuals that way, and I must tell you that uniformly it works. And I'll just tell you also anecdotally that a patient walked in with a $40,000 bill unpaid from his hospitalization. Everything was denied by Blue Cross Blue Shield, and I told them that in the event that you don't pay these bills, I'm going to court on behalf of the patient. They paid everything.
I like that hardcore approach. So we've talked many of us have talked about surveillance and follow-up imaging. And one of the questions is about, we get all these scans, CAT scans or PET scans. Is there a limit onto how many CAT scans you may order for the patient? What about radiation, cumulative dose? Anyone want to discuss your thoughts on surveillance, keeping in mind how much radiation they may be getting from CAT scans?
So the scans that we have are all real, and you're right, they all have minor side effects, and they may be a little bit cumulative, just a little bit. So it'd be one thing if you were 7 years old and you needed the lifelong worth of scans, but you're 70 years old, the information is probably more beneficial than the radiation exposure. Okay, so just understand that. One dose of Lutathera is like 100 CT scans, right? So just put it into context. But there are some truths to it, right? Contrast is not perfect. There's some thought that even the MRI is not perfect, and there's a tiny little bit of radiation that comes from PET. But in general, imaging is not terrible. The real problem is just over-imaging you, right? Doing something you don't need to do. So if you're trying to figure things out, right? So as Dr. Reedy said, the only test that works 100% of the time is a test of time, right? It's the only test that always works. So if you're trying to figure out the tempo of your disease and you're not on treatment, you want to keep a slightly closer eye onto it, fine. Every 3 months is very, very reasonable. But if you're already like 3 or 4 years out from your surgery, disease is very, very stable, very, very quiet, you're on your lanreotide or your sandostatin and everything's okay, maybe you can do it once a year, right? But those are the kinds of things that you must have and this is why it's good to have a specialist, right? So you want to get a sense of what that personality of your cancer is like in order to decide how often you can get away with looking at it. And remember, MRI is not radioactive, right? There's no radiation in MRI, but it's only good for certain things. The CT is very, very good and very standardized, but there's some radiation. And the PET is expensive with a teeny, tiny little bit of radiation.
Thank you.
But the echo is free, pretty much, yeah. You can have an echo every day, you'd probably be okay.
Great. So this is a question I think that's valuable with regards to biomarkers in imaging. Do they correlate? What's the significance if they do not correlate? So for example, if your CAT scan shows progression but your biomarkers are stable, or vice versa, your biomarkers are going up and your CAT scans are stable, significance or thoughts on that kind of scenario?
Yeah, I mean, I think any imaging trumps biomarkers. So even if the biomarker is stable and the imaging shows progression of disease, that's something that we want to address and decide what, if anything, interventions need to be considered. Like we said this morning, I think the problem with the biomarkers is depending on which one you're talking about and how reliable and comfortable you are with that number in the presence of stable disease. There are places that sometimes our disease can grow and we don't see it as well, particularly in the abdominal cavity, so what we call miliary disease. So miliary disease is just tiny little sort of deposits of neuroendocrine. So I think that if it was going up and you're more symptomatic, then we're always just going in front of the patient and how are you feeling, how are you doing. So I would say that most imaging today, like Eric shared, is so much better than it was before, but it's not perfect. So I think if you had a biomarker and you were definitely more symptomatic, we would want to look a little bit more carefully.
Anybody want anything to that? Okay, good.
I agree with that.
Sticking with the imaging for a second, are there any other cancers that can be detected with the gallium dotatate or copper dotatate scan?
Generally, no. Somatostatin receptor is very, very specific. There are other tumors that express very low level of somatostatin receptors. So you can see it a little bit in lung cancer. You can see a tiny little bit in lymphomas. But it's not been robustly tested in other cancers. It probably would be a good thing to do. You can see a little bit, but the signal tends to be much lower for other kinds of cancers than if you see it on a high one. But at the same time, you also get a non-contrast CT scan. So in theory, you might be able to pick something else up, but generally no.
Yeah, I would agree. The other one, though, that does sometimes pick it up, again, much lower, is breast cancer. So we've actually, and we've talked about this earlier, actually Marianne said, don't forget your mammograms and screening, because we absolutely have patients in neuroendocrine can get a second primary, and that happens. And so we've had patients before that there's a new lesion in the breast and it's thought to just be somatostatin positive and neuroendocrine, and it actually turns out to be primary breast cancer. So that is something that we want to always watch.
But there are false positives as well. Not false positives,
Yes.
they're real. But so Dr. Reedy said that you can get a little bit of activity in the head of the pancreas, absolutely true. But you can have something called a meningioma, okay, which is a little growth in the lining of your brain, of your central nervous system. And they are generally benign. They're not always. So we have done that before. We found some big honking thing and they had to have surgery to kind of get this thing removed. But that's generally not that common.
Yeah, and to the point, just a quick anecdote to that. I had a patient with a meningioma, and they do have somatostatin receptors. So when she got her PRRT for her neuroendocrine cancer, the meningioma got some PRRT as well, and she had a seizure. Now, yeah. I mean, eventually, thankfully, the meningioma went away with the PRRT as well. But it is something that is, anything that has somatostatin receptors will get the PRRT.
We'll continue the line on the PRRT and a question for both Dr. Liu and Dr. Reddy with regarding to sequencing. If capecitabine and temozolomide have some myelosuppression and PRT has some bone marrow toxicity, how do you deal with it? Sequencing it? If someone has the myelosuppression from the CAPE-10, are they ineligible for the PRT?
Yeah, really great questions. And so this is like how you have to thread the needle carefully on giving these therapies and making sure that our patients are offered all of these treatments. So, I think it really depends on which one you give first now. We always stop CAPE-10. I usually don't give more than 9 cycles. Again, that one study says definitely don't give more than 12. What was great about our series was when we actually, for whatever reason, when we stopped the treatment, not only did some of our patients have stable disease, but 60% of our patients had stable disease and or continued tumor shrinkage off all therapies, not even on a somatostatin analog, for at least 9 months or longer. So there's something really interesting and unique about the temozolomide combination with the capecitabine. We generally use CAPE-10 first because it's easy. It's literally pulling it off the shelf as opposed to getting PET scans followed by PRRT, which take a little bit longer. But it's not to say that one's necessarily better than the other. It's just logistically a little easier to get the CAPE 10 for. This is for predominantly pancreatic neuroendocrine cancers, although lung nets as well as some duodenal and gastric nets also have beautiful responses to CAPE 10.
Eric, in patients who have liver lesions that are not amenable to surgery.
What?
I know.
What?
For the,
Who told you that? Medical oncologist? Cardiologist, perhaps?
your preference or options, Lutathera, embolization, and how do you decide on which options to go next if surgery is not an option for control of liver disease?
So there's some truth to that. I mean, I'm teasing a little bit because I think people underestimate what is accessible. I mean, we can remove big tumors in very, very gnarly places. Not everyone can, but you get used to it. You can certainly get them. But let's say the person's not well enough to undergo a big operation. They have heart disease, or they're elderly, or they don't want to have an operation, right? Wanting to have an operation is a contraindication to having an operation. Right? So those kinds of things depend on what you're going after. So if a patient has what we call the miliary disease that Dr. Reedy just mentioned, like spread all over the liver, embolization is probably the best way to go after it because you can treat the whole liver. But then there are different types of embolization you can do, which she had mentioned in that RETNet study. For large tumors that are very focal and the patient does not need to or want to undergo surgery, we actually shoot a ton of radiation into it. And we saturate the tumor with radiation through the embolization technique, and it burns it and kills it, so it goes away. It's called a radiation segmentectomy. And then the other thing we can do is you can stick a needle anywhere in the liver. So if we can ablate it, sometimes you can stick a needle into it and you can either freeze it or burn it or microwave it or something like that, and you can get rid of it. So again, as with everything, as you've all learned today, you need to see someone who knows how to do this so you can figure out which way to go, because unlike the other cancers, there's no path. It's a web, right? And so someone has to guide you through the web.
Great, thank you. Going on with clinical trial talk, Dr. Reddy, there's a question for you regarding for the patients for the sub-Q injection of octreotide study. Can you go over the logistics or the methodology for the injections?
Yeah, so that is a study that's subcutaneous. It's administered, if you're comfortable, at your home once every 2 weeks, one time, which is kind of nice. It's a little bit more often than the IM, but it is sort of self-administered. If you're not comfortable with it, then you could come to clinic to get it done as well. I will say, I forgot, like Eric said, there is the DEB-TATE study. So that's a PRRT that we do have open trial at MSK. And it's potentially what we call longer acting, so that the PRRT is thought to be going to stay in the system longer than the traditional Lutathera that we're using today. And so there's only 2 treatments instead of 4. So it's an interesting concept of being able to use PRRT shorter doses, only 2 instead of 4, but maybe staying around for a longer period of time.
This is a question also. Hopefully I have this question right. Is there plans for a study for patients with well-differentiated neuroendocrine tumors and minimal symptoms? So let's say someone maybe, why isn't there not a registry trial for such patients so we can know what happens to them? I mean, there's a lot of patients out there who have minimal symptoms, maybe stable disease, scattered throughout the country. Should there be a registry trial just to capture those patients? That's a big question.
I love that question.
Yeah.
Who did that question?
Yeah, I think you're right. I think there probably should be something.
Because Dr. Lou that I love, he gets all the credit sometimes for all that surgery that made all the tumors go away. But then I say, here's my patient. It never did anything for 5 years. And so sometimes we take credit for good biology. True? True. And so I think that
I will not lie to you.
such an important
I will not lie to
question.
you. Dr. Reedy is the one who convinced me to not always jump on it right away. She told me that, and I don't. The test of time is actually the much better time.
Yeah, and just in spite of us, thank heavens, many of our patients are going to do so well without anything at all. So if we can learn from them, I think that would be so critical and helpful. And so I try to wave the flag as much as I can on symposiums like this. But you're right, we need to learn it and study it
But
more.
registry studies are hard to do.
Registry studies are hard because there's a lot of what we call selection bias there, where the patients that enroll are may be different than those that don't enroll. But I do think we do have a big registry study that we actually started through a program called REDCap. And what's great about REDCap, one of the biggest problems particularly in rare diseases, is to get these databases. All of us had a different type of database forever. So it was so hard, and not that we didn't want to collaborate together, but we just didn't talk to each other, literally able to, because of the different databases and the different variables, et cetera. But we finally got together with UCSF and now Stanford at one REDCap database where we're following the same variables for our patients. We started it at when they're getting PRT to be able to put in as much data as we can and learn.
Great, I agree. I think. There's a question regarding, is there a name for the test panel for the mutation analysis that you did for your patients for neuroendocrine tumors?
So at MSK, it's called IMPACT, but it's just anywhere else, it's called Next Generation Sequencing. The most common platform is Foundation One. Caris also has one. There's several that are out there now.
Do you routinely test all your pancreatic neuroendocrine tumors for germline mutations?
So our Next Generation Sequencing platform allows us to test both germline and somatic. I think for the guidelines, like the NCCN guidelines that I discussed, we say that anyone with a family history suggestive, which really has to come from your oncologist to ask the right questions, definitely should get germline mutation testing, but that it's not routinely done.
One of the questions was regarding a patient with carcinoid syndrome having difficulties with memory and cognitive loss. A common question, maybe they've received some sort of treatment, and now they're having issues. First, Doctor, what about the cardiac heart disease and its effect on cognitive or fatigue?
I think with respect to that question, it would depend upon whether or not there's uncontrolled heart failure, which decreases the perfusion to the brain and would account for that. Otherwise, it's well known that carcinoid syndrome can have an effect on mentation.
So in the absence of heart disease, Dr. Reddy, your thoughts on cognitive loss, carcinoid syndrome and management? I mean, besides supportive care, I'm not sure there's much to offer.
No, I wish I had it, except to say that patients feel it. So I don't think anyone's, I do think there could be an issue. And even in patients that don't have carcinoid syndrome, we sort of talk about chemo brain for our patients, but there is something about whether it's the fatigue that leads to sort of the inability to be as quick as we used to be or something. So I don't have an answer for it, except to say that I definitely have seen it.
Lastly, one of the questions was, is Dr. Liu a neuroradiologist? I'll have you answer that question.
I'm an amateur everything.
Okay. I think there's great validity to that question because as opposed to a radiologist who may see periodic neuroendocrine tumor scans, experts like Dr. Liu, Dr. Reddy, myself, and others, Gerstein, we see a lot of these scans often, probably more so than the regular radiologist would see. So we do have some expertise. Unfortunately, the three of us, or many of us, all work in institutions where we have radiologists who do specialize in neuroendocrine and nuclear medicine to be able to answer some of those questions.
Yeah, I mean, the really important thing is, so I'm not that smart. My wife reminds me every day. But I just do it every single day, right? Which means that my nurses do it every single day, which means my radiologists do it every single day, which means my cardiologist see it every day, which means my pathologist sees so many of them that she's just like, this is not even interesting anymore, right? It's what we do routinely. So you want to go see someone and be care for a team that sees this routinely because they're not surprised, right? So for example, a fair number of patients fly to Denver for me to do their operation. And when they come, they say, I'm a patient of Dr. Liu's. Immediately, they know exactly what you have. They know what they're going to do. There's a whole protocol. There's nothing fancy. And so everyone's aware, right? Anesthesia, for example, with patients who have neuroendocrine is a big, surgery is a big deal for everyone. But for neuroendocrine especially, it's a huge deal because the anesthesia can be such a problem because of all the hormones and things and the medicines and stuff that are going on. So I never worry about that. None of us ever worry about that because we know how to do this. No one ever succumbs to carcinoid crisis at our institution because we have it controlled the moment it happens. It never happens for more than 30 to 60 seconds because we can fix it so fast. And that's the kind of thing you want to feel comfortable with when you go to see your, your physicians and your team taking care of you.
And the last question, which I probably will pose there and maybe have Bob or Marianne answer when they come and give closing remarks, says, where can a list of NET specialists be found?
Right here.
That's it, 94.
Fortunately, there are others for geographic, there are others out there, yes.
But on Long Island.
But correct. But it's a small community. We know them all, but there are many others. But I think maybe Bob and Marianne can answer because it's a great question. Where can I find a list?
So I'll just mention that Carcinoid Cancer Foundation maintains a list by area of the country.
I guess so. A follow-up to that, though, those questions says not all of them say specialist, and I think the way Carcinoid Foundation defines specialist or non-specialist may be a bit vague for the population. But I agree. I think it's a great resource because even if they may not say specialist, they've at least submitted or have some interest or some expertise in that. I'll leave it over and give it to Bob.
Okay. Well, let me just address that first. If you visit our website, you'll see that there are no NET specialists listed. But there is a reason for that, because every advocacy group kind of has a niche. And if we do exactly what Carcinoid Cancer Foundation does, or NET Research Foundation or whatever, kind of wastes the precious funds that we have. So we're more, I'll say, I think the picture we have is that it's kind of family oriented. We're here, we'll talk to you if you call the hotline. If you need to talk for 2 hours, we'll do it. Some groups have 7-minute limits, things like that. They do different things. So we'll tell you about the NET specialists that we know, and you'll be able to get the name, but we're not going to speak to you about anybody that we don't know very well as an expert. So it's a different approach. Carcinoid Cancer Foundation has a list. They have the wherewithal to vet that list and that kind of thing. So it's a little different, but I think the end result is we're all trying to get the patients the best information we can.